All right, we're going to go ahead and get started with today's webinar on the myths and the misconceptions around low testosterone treatment. My name is Brandon Addison. I'm one of the hormone consultants here at Charleston Testosterone, also known as West Ashley Wellness. And again, like I said, if you guys have any questions at all, don't hesitate to put something in the chat box. I'll be more than happy to answer your questions. If you guys have any questions at all, that don't get addressed, please write them down, give us a call at the clinic, and we'll be more than happy to go over anything with you as well. All right, so the first thing I want to talk about, I want to do a little bit of an educational piece before we get into the myths and misconceptions, because it will actually help me explain why some of these myths are either wrong or true. So to get started, let me go ahead and talk about some people. You'll hear some doctors refer to low T not even being a real medical issue. They just assume that it's just absolutely normal and not a big deal, that men's testosterone declines over age, and it's just a simple part of aging and getting older and shouldn't be addressed. That is not correct at all. And in fact, based on the guidelines set forth by some of the thought leaders in hormone replacement, 1 out of 4 men over 40 these days actually has a condition known as low testosterone. That means they are experiencing some of the symptoms. We're going to talk about these symptoms: decreased libido, a lack of energy, a lack of focus and concentration, any kind of decrease in muscle size, strength, or endurance, any height loss over the last year or so, just a general decrease in enjoyment of life, frequency sad, down, frustrated, irritable, having mood swings. All of these are symptoms of low testosterone. There are people think that testosterone has a huge impact in the bedroom. It has a much greater impact on libido than actual performance in the bedroom, but it does trickle into the bedroom performance a little bit. But it's more along the lines of your focus, your concentration, your energy levels, losing muscle and gaining fat, especially that belly fat, are some of the more predominant and more primary symptoms of low testosterone. There's a few more listed there on your screen. Definitely take a look at them. But the biggest thing, again, is if you've just had a loss of enjoyment of life recently, you can't focus and concentrate, especially in the evening hours. You've just lost that ability to get off the couch and go do something productive, coupled with a loss of muscle and gaining belly fat and loss of libido. Those are all signs of low T. You definitely don't have to have all of them to be experiencing a low testosterone condition. If you have any of them, a lot of times it's a good idea to go and get your testosterone levels checked, because you could be starting the downhill slope on low testosterone. So I'm not going to get into this too much. I'm not going to talk about the science of low testosterone too much, because this is more of a myths and misconceptions webinar, but I do want to explain how the male body manages testosterone. There's an axis in the body called the hypothalamic pituitary testicular axis, and it basically describes how the hypothalamus talks to the pituitary, how the pituitary talks to the testicles, and then when testosterone is created, again, what the hypothalamus does. This is a loop in the body, and it manages levels of testosterone. The body cannot just go out and produce all the testosterone it wants. You'll have levels that are far too high. So the body has to determine what an appropriate level is, and at all times the hypothalamus is looking for testosterone in the body at that appropriate level. Now, when the level in the body decreases below that appropriate level, it releases what's called gonadotropin releasing hormone, and that stimulates the pituitary to release a hormone as well called luteinizing hormone. And that is what creates the process in the testicles that produces testosterone. Okay, it's fairly simple. The hypothalamus is looking for testosterone. When it sees it's going away, it releases that gonadotropin releasing hormone. That in turn stimulates the pituitary to release luteinizing hormone, and the testicles pick up that luteinizing hormone in the bloodstream. They know it's time to create testosterone, and they do it as long as there's luteinizing hormone in the body. So whenever the hypothalamus sees that there's plenty of testosterone, it stops the process, which in turn stops the pituitary from producing LH, which in turn stops the testicles from producing testosterone. It's a negative feedback loop that just always determines that, hey, when I'm high, I'm not going to be producing testosterone, but when I get low, we're going to kickstart the process and produce testosterone. So, hypogonadism is the medical term for having low testosterone. And you can see in that last axis, there are multiple points of failure. There are two basic types of hypogonadism. One is primary hypogonadism, and that means there's just no biological function left in the testicles to produce testosterone. Now that's total primary failure. You can also have partial primary failure, where your body can only produce 70% of what it was once capable of, or 50% of what it was once capable of. But if the limiting factor is testicular, is the testicles, then that means you have primary hypogonadism. Secondary hypogonadism just means, hey, I'm not flagging my body to go out and produce it. If you have some sort of pituitary degradation, and there's a million reasons why this happens, but if the pituitary is not releasing that luteinizing hormone for whatever reason, then the testicles aren't going to be producing testosterone. Okay, so again, if the limiting factor is we're not flagging the hormones to produce the testosterone, that's secondary. If the limiting factor is you just do not have the biological function of the testicles anymore to do it, then that's primary. Okay, now that we've talked about that, I also want to talk about the difference in the way that testosterone is managed today versus how it was managed in the past, and still currently with practitioners that don't necessarily know exactly what they're doing. And this happens all the time, I promise you. This slide, we're going to talk about a patient named Bob. The yellow part of that bar graph is his own natural production of testosterone. Now, he needs to be at 100 to be optimal. That's the level that Bob needs to be at to be optimal. So he has, you can see he can only produce 70% of that 100. That means he has partial primary hypogonadism. He can only produce 70%. But he's still only producing 50 because there's some wasted potential. He's also experiencing some secondary effects. So for whatever reason, his pituitary is not flagging his body to produce that full 70%. So he's going to the doctor. When they run his blood work, they can tell he's at about 50% of where he needs to be. So on day 7, he's going to get his prescription in the mail. He's going to inject himself, and on day 7 and through the next few days, Bob is going to feel like a new man. He still has that wasted potential. That's the 100 to 120 that you see at the top of that second bar. However, if you add the yellow and the blue together, he has 100% of the testosterone in his body that he needs in order to feel optimal. But there's that axis again, that feedback loop that we talked about earlier. Because there's all of this testosterone floating around in his system, his body is not going to produce those flagging hormones to tell his testicles to keep producing the testosterone. So what's going to happen is his natural endogenous production is going to drop, and it's going to completely drop. So now by day 60, when Bob goes back in to see the doctor's going to run the blood work, and now the doctor can't understand why he basically is at the same level he was before, when he knows he's given him twice as much as he had originally. This is the fundamental issue with the way a lot of doctors handle testosterone replacement. So that doctor's going to scratch his head and just go, I guess you need a bigger dose, so let's give you twice as much. Now, 6 or 7 days later, when he gets his prescription, he injects himself with twice as much. Even though he's not producing any of his own testosterone, he's still at that 100% mark that he needs to be optimal. Now, this is good and bad. Having optimal levels of testosterone in your body is fantastic for a man. It prevents heart disease, diabetes, osteoporosis. It prevents metabolic syndrome and many, many other issues. But the problem is he is suffering from testicular atrophy if he goes on for years in this state, because he will have gone years without using his testicles to produce any testosterone at all. And any tissue in the body, if you don't use it for extended periods of time, will atrophy. And the testicles are no different. So Bob, even though moving forward, he's at optimal levels of testosterone. It's cardioprotective. He's experiencing the lifestyle benefits. He's experiencing much better issues with putting on muscle, with losing fat. He's a better dad, a better husband, a better businessman. All of that stuff is great, but again, his testicular health is not going to be the greatest just because he's suffering from atrophy. Moving forward, this is how we do it at Charleston Testosterone. HCG, not HGH, make sure you don't confuse the two. HCG is a hormone that is unbelievably close to luteinizing hormone. So luteinizing hormone, again, is that hormone that triggers a man's testicles to go out and produce testosterone. So we know what happened to Bob. Jim walks in on the same day with exactly the same blood work. Okay, he's at 50% of that 100% as far as actual testosterone in his body, and he also is experiencing some secondary hypogonadism where he could be all the way up to 70, but he's not, just because he has some sort of pituitary degradation. Maybe he's on an antidepressant, or maybe he's just got a little bit of chronic fatigue going on, or some sort of metabolic issue. Whatever it is, it doesn't matter, because what we're going to do with him is the first thing we're going to do is put him on HCG, and that's going to bridge that gap between 50 and 70. If he has testicular function that can be optimized, HCG is going to do that. So what that means is, instead of having to give him a big dose of testosterone to overcome the fact that we've shut down all of his testicular function, we're actually going to optimize Jim's testicular function. He's producing all the way up to 70% of that 100 now, which means we only have to give him the additional 30. Remember, at the end of the game, or at the end of the 2 months earlier, Bob was having to be injected with 100% of his required testosterone, where Jim now is only going to be at 30% of that exogenous hormone. Exogenous means it's introduced from a third-party source. So, again, with that being said, day 7, Bob was feeling great, remember, because he was at 100%. Jim is also at 100% and he's feeling great. But the difference is, because of the HCG, Jim is not going to lose his own testicular function. He's going to stay optimized. He's going to keep producing every bit that he can. So instead of that big seesaw like you saw Bob on, Jim is just going to be feeling great all the way through. And the most important thing is his own testicular function is going to remain not only intact but optimized throughout the duration of his testosterone therapy. So Jim is healthier in the long run because his testicular function is intact, and we also have to give him only 30% of what we had to give Bob because we're doing it right, and Bob's doctor didn't quite know what he was doing with testosterone. So now you guys understand the basics of how testosterone works and how the therapy works in conjunction with HCG as a successful co-traveler to the prescription. So now let's just go ahead and get started on the myths and misconceptions. The first one is, and I hear this every day from a patient, once I start, I can never stop, right? And the truth of that is false. Again, you guys know enough already to know the difference between Bob and Jim. If Bob goes 2 or 3 or 4 years without producing anything, he's going to have trouble producing hardly anything at all, even if he gets it right with HCG down the road, because that, again, that biological function in the body can permanently atrophy. Where if Jim has to come off the therapy for whatever reason, he's still going to be optimally producing testosterone up to whatever level he can. Now, he's not going to be at 100 anymore just because he doesn't have the faculties to do so, but he definitely can stay at 70%. Okay, so there's an old adage that once you start, you can never come off. Again, if it's done right, with the right medical supervision and the right diagnosing and prescribing protocols with the appropriate co-travelers, that's not true at all. Okay. The next myth, and even a lot of doctors are afraid of this because there's just so many rumors out there floating around about, about testosterone being bad. One of those rumors is that it causes cancer, and this has absolutely been debunked in every major study recently, where the biggest thing with testosterone is it is a drug. I mean, it's a naturally occurring hormone, but when it's introduced, it's a drug. And if you give someone 35 aspirin a day for several years, that's not just going to make them sick. Like, that could kill them. So testosterone is no different if it's not medically, if it's done in ways that are not medically supervised. If you have guys getting testosterone from someone's trunk at the local Gold's Gym, there's no telling what could happen. At that point, it's a black market narcotic, and that has absolutely no impact on what a medically supervised program with true medical intervention with trained doctors can do for that patient. So if someone is on super high levels of testosterone, keeping their body in an anabolic state for very long periods of time, sure, a lot of things can happen. But we're not interested in that scenario. We're interested in physiologically appropriate dosing measures and constant medical supervision by a practitioner that knows what they're doing. In that scenario, there's never been a link to cancer being caused by testosterone replacement. Okay? One thing to note in this, when we're talking about cancer, if a patient develops prostate cancer while they're on testosterone, now again, it's been proven that healthy testosterone levels actually mitigate prostate cancer from forming, but there are absolutely exceptions to the rule. 1 out of 6 men develop prostate issues. Okay, so it's not a foolproof thing. It will help you limit your exposure to prostate cancer, but it's not a perfect solution. So if a man develops prostate cancer, he has to come off testosterone immediately. Prostate cancer, the aromatase enzyme in the prostate cancer cells absolutely loves testosterone. It devours it, and it grows quickly when there's high levels of testosterone. So one of the things that a lot of doctors do, or a lot of urologists do, whenever a patient does develop prostate cancer, is they shut down testosterone production completely in the body. That really slows the growth of the prostate tumor until they can go in there and get it out. Now, once the patient has been clean for 12 months, now again, we're very, very strict about this. Once a patient has been prostate cancer clean for 12 months, we can start them back on the program, but we don't take any chances with a patient's health, and we actually use that as one of our contraindications. So prostate cancer in a patient's medical history has to be at least 12 months old before we can look at putting them back on the program. Okay? But again, as far as all of the types of cancer, testosterone actually helps prevent it, and it definitely doesn't cause it. The third myth is that it can reduce sperm count. That is absolutely true. Okay, HCG, even when done right, does not tell the testicles to produce sperm. It tells the testicles to produce testosterone. Now, if here at Charleston Testosterone, one of our questions up front in the first consultation is, do you want to have children in the near future? And if the patient says yes, it's no problem at all. We have additional prescriptions that we can give that patient. A very simple little drug is called Clomid that will actually produce sperm while they're on testosterone. And we by no means do any sort of fertility work. That's not something we're interested in at all. But a lot of men, the very first thing when they go to a doctor, if they want to increase sperm count, is the doctor will put them on HCG and Clomid together. And that's what we do for patients as well that want to have kids in the near future. So again, the traditional route of testosterone or the newer route of doing testosterone with HCG will reduce sperm count. However, when co-traveled appropriately with Clomid, it really boosts the sperm count higher than it would have been otherwise. Now, even though, I always say this as a caveat, even though testosterone replacement will absolutely bottom out your sperm count, don't use this as any sort of birth control protocol. It's not that reliable at all. So, and in fact, because the libido will increase, you're going to be feeling better, in a better mood. Even though sperm count goes down, a lot of people will get pregnant on, when the man gets on testosterone therapy, simply because sex becomes more frequent. The next myth is that testosterone can cause roid rage or just anger fits, or that's completely false. In fact, testosterone mitigates things like moodiness, things like depression, any kind of these personality, I don't want to say disorders, but just personality issues of being depressed all the time, being in a bad mood, being irritable, having mood swings. Testosterone fixes those problems. So it actually does the opposite. Roid rage, like true roid rage, comes from a physiological change in the brain due to extended levels of, or extended time periods of anabolic levels in the brain. So if you keep your body in an anabolic stage for extended periods of time, your brain chemistry actually changes, and those fits of uncontrollable anger do happen. But normally that's going to be either a result of anabolic steroids or other things that affect those receptors in the brain, and not testosterone, and absolutely not testosterone in physiologically appropriate levels. So, moving on to the next myth. This happens all the time. All the time. Patients know something's wrong, they'll go to their doctor, they get their blood work ran, and they'll come back and, their level will be somewhere around 300 or 350 or something like that. And their doctor goes, well, that's within range. You're low normal, but you're still normal, so you don't need testosterone. The problem with that is some people walk around as a 25-year-old at a level of 400, let's say, and other people walk around at 25 at a level of 1,000. So that one marker, the patient being at 350, we don't know what that means for that individual patient just based on the blood work at all. If that patient was walking around at 400 when he was 25, no, he doesn't need testosterone replacement. But if he was the guy walking around at 1,000, now he's at a third of what he should be. He absolutely needs it. So we have to couple our diagnosing and prescribing protocols not only with blood work, but with the symptomatic qualifications as well. And it's also, we need to understand things like their current health factors, exercise patterns, sleep patterns, lifestyle factors, and more. Okay, so just because you're within range on a very particular test, it doesn't mean anything for you individually, because those tests have to be written in a way that makes sense for the general population, and the variability of where one guy is at 25 versus another guy is, it makes that big bell curve of normal, quote unquote normal, for testosterone testing almost useless. Okay, so if your doctor's told you were low normal and that you shouldn't be on testosterone, come in and talk to us. We want to have a much more comprehensive consultation with you, figure out how symptomatically qualified you are, other factors going on in your body, and we want to look at things like what your pituitary function looks like. That's going to be part of our initial lab work. So all of our consultations are free. If we end up doing lab work with you, the lab work we basically just break even on up front. So it definitely makes sense from a health perspective and a financial perspective to come in and get checked out if you think you have any of these symptoms at all. All right, the next myth I want to talk about is the heart attack and testosterone link. I know you guys have seen commercials where these lawyers last year were trying to amass patients for a class action lawsuit. This was going on all over the country. Well, there were over 1,200 of these lawsuits filed, and not a single one has ever beat one of the testosterone manufacturers. Okay, the only testosterone manufacturer to ever lose a lawsuit regarding the testosterone is Androgel, and they lost the lawsuit based on advertising principles. They basically got beat by the same set of laws that made Joe Camel or that made Camel tobacco stop using Joe Camel because they thought they were advertising to children. That's the only person, or the only group, that ever lost a testosterone lawsuit. The rest were laughed out of court because, like any other drug, there are dangers if you're using it in inappropriate levels and you're not medically supervising your patients. So that's why if you guys are considering using testosterone, use a doctor that knows what they're doing. Make sure you get routine blood work, and absolutely make sure you're getting the best pharmaceutical grade drugs that you can get. Okay, one of the issues with the quote-unquote heart attack link is red blood cell count will actually increase. Okay, and the issue with that is, that's called polycythemia when your red blood cell counts increase. That is not a cardiac risk by itself at all, because everyone in the country that lives, or in the world that lives at elevation, they have polycythemia. They have much higher red blood cell counts than the rest of the people that live at sea level, and there's no greater occurrence of cardiac risks at all at elevation versus at sea level. So there are a lot of other factors. Now that definitely can be one piece of the puzzle if someone is having cardiac risk, but it's only one piece of the puzzle, and it needs to be coupled with many other factors before you can truly consider that person a cardiac risk. The real cardiac risk is estrogen management. If you drop a man's estrogen levels to extremely low levels, now that patient can become a cardiac risk just because of the cardioprotective nature of estrogen in a man's body. And that's something else that we're not going to talk about it on this webinar, but here at Charleston Testosterone, that is one of the other factors that we manage very, very closely with our patients in our testosterone therapy. All right, those are the 6 main myths and misconceptions that come up daily here in our clinic with patients that read something, or their primary tells them something. So if you guys have any questions regarding this, if you guys have any additional add-on information, don't hesitate to give us a call. Our website is charlestontestosterone.com. There's a form on the website at the contact page. You can send us any information or any questions you want there, or just pick up the phone and give us a call at 843-405-7509. Again, my name is Brandon Addison. Feel free to give us a call if we can do anything for you, and thank you so much for listening to the webinar. Have a great day, folks.